Anything but COVID, an open forum. During the last 6 months, many developments have happened in medicine, yet few have gained much notice as the news has been dominated by the coronavirus. This is an opportunity to go over the things that have happened in the last 6 months that don't involve COVID-19. Dr. Peter Nord was a VP CMO at Unity Health Toronto. He is the founder of Stillbrook Accessible Retirement Residences, a registered charity focused on developing affordable retirement living communities for lower socioeconomic frail seniors across Ontario. Peter, actually, we should talk about this at some point. He's a member of the Premier's Council on Improving Healthcare in Ontario. That sounds interesting, and we should talk about that at some point. And an assistant professor at the University of Toronto. How are you, Peter?
Doing well. Thanks for having me on.
Okay, do you want to provide your pandemic update a little bit?
Yeah, well, I'm sure at this point everybody is almost overwhelmed by the amount of media headlines that are coming at us every hour of every day. I think the takeaway for me, and this may be sounding a little controversial, but we've actually won. Like, we've won the battle, and we haven't won the war yet, but we've won the battle. Clearly, the big concern now is, how do we think about getting back to some sort of normalcy from an economic perspective, from a commercial perspective, and then how do we watch for and stave off a second wave in the fall, and then wait for the vaccine to come along. Footnote on the vaccine: no vaccine is 100%. So for people to be thinking that the holy grail of this is the vaccine, we need to really rethink that. I mean, if we can get a vaccine that's 50% successful, that's a massive win. So, some people are out there thinking, well, it's 100% effective. It's like saying our flu shot in the fall is 100% effective. And as we all know, on a given year, sometimes you don't quite get the match 100% right. And it's, 50, 60, 70, 80%. 80% would be a good year for the flu shot effectiveness. So we strongly suspect that the vaccine will be good and certainly a benefit, but not 100% panacea for our future. So the takeaway message is that we're living with this virus for quite some time. Social distancing is going to be with us for quite some time. But as we back into where I started, like, we've won the battle, obviously the case rate, those numbers that we see climbing, especially some regions of the United States over the last couple of weeks, which create real concern. The numbers themselves aren't actually bad or good. So, if we assume that 6 to 10% of those that we test are positive, it means, multiply by a factor of 9 or 10 your positive case rate for the number of people who have actually been tested. Again, 90+% are actually testing negative at this point. But over time, we will be getting more positivity. Again, this idea of herd immunity is going to be coming our way over the next year very gradually. So the numbers will start to increase gradually over time. But just to go back to the first principles, we did all of this work, all the masks and the hand hygiene and the social distancing, all of that was to slow the curve. So we talked about flattening the curve so that our health system wasn't overrun. Well, in Canada, the takeaway message is we've never even been close to overrunning our healthcare system. We have always had ICU capacity. We've always had ventilator capacity. A couple of spot regions have had we got close in a bit in April. But at this point in June, the hospitalization rate, which is actually the rate that I like to watch, hospitalization rate, ICU rate, and ventilator use rate, those are really the takeaway bellwether kind of markers that we want to really pay attention to. And those numbers have been going entirely in the right direction. And actually in most jurisdictions, even in the US, in most areas of the US, even if you're seeing increasing case rates, the actual positivity, COVID positive cases, the hospitalization rates in many areas have just gone down. Now, having said that, you take away Florida. So Florida has a unique demographic, right? It's got the young people, all the people on the beaches, but then you've got the silver generation. You got vast numbers of seniors that, of course, are our high-risk population. So when you put together the two, where you have young people getting together on the beach, sharing the virus, they're fine. Like the positive case rate's going to shoot up, but it's not really going to affect them very much. What they are going to do is create a vector for transmission to their friends, of their grandparents. And so what we're seeing in Florida is their health system is actually getting maxed out. So those are the situations that you absolutely need to lock down, restrict, protect the population as much as you can, and really prevent those elderly people from overrunning your healthcare system. So that's where I say in Canada, we've really won the battle. The battle was flatten the curve, make sure that our capacity in our health system is always greater than the demand on our healthcare system. And we're there, and we've been there now for some time. So the takeaway is, let's get going. Let's get back to as much of a normal life as we possibly can, and get back to work. Because at some point, the impact, and we're going to talk about this in one way, that the impact of social isolation and lockdowns and economic restrictions become greater than the impact of COVID. And that's the inflection point that we're in right now. So even in Ontario, we may see our case rates start to become worse, that doesn't matter. As long as our hospitalization rates are going down in the right direction, it means let's get back to work. Let's open up the restaurants, maintaining social distancing. Let's get the dine-in going. Let's get people back to business, back to work as much as they can. The new world is different with working from home, and as evidenced by Chris being at his cottage, and I'm in my condo right now, and we're still doing this. We started out before COVID being in the same room, and we don't do that anymore. So, and we may choose not to. So it is a bit of a new world, but at this point, other than watching for a worrisome second wave, which would be bad news for the economy and for our health, at the end of the day, it's now time to get back to an economic reality that's going to work for everybody. So that's kind of the latest and greatest, COVID, according to Nord this week.
That's fantastic. Peter, just a quick question. And we are doing the webinar next week is about the U.S. border and considerations involving the U.S. border. But if you were to bet when we are be able to go to the United States, deal.
Yeah.
Peter, can you hear me?
Yeah, you were broken up a little bit, but I think I got the question about U.S. border and opening and when we can start to move. It's a really good question. There's competing priorities as we move forward on the whole border question. Right now, what we're seeing, the U.S. media makes it look like every American citizen has got COVID, and if we open the border, we're going to just go back, and it's going to trigger a second wave. That's really not the case. There are certainly, as I said, regions that are real hotspots, and so you have to weigh again the benefit of the tourist dollars coming in against the potential risk of having COVID being brought in as well. And the difference even between air travel and land travel. So will we open up air travel between US and Canada because we can control the airport, we can control the plane? Do we put a 14-day isolation on everybody who comes across? If people are coming across the border by car, much more difficult to manage that. So do we say it's okay by air because we have control points all the way along, plus a 14-day isolation, and then hold off on land? Or does that not make sense? Like right now, we need commercial traffic across the border to keep our economy solid. But boy, when it comes to just the average person wanting to do visit for tourism both sides of the border, it's a very difficult question. I think it's too early right now. I think the consensus is It's much too early. There's too much activity happening in the U.S. They are not in some areas not really taking it as seriously as maybe they should. But also we have to be careful about what we see in the media and the headlines. And the scientists would say there's hotspots, and those hotspots tend to get the headlines. So probably not as bad as what we're seeing in a lot of the US and Canadian media around the States. But having said that, definitely not ready to open the border at this point.
Fantastic. Well, let's move it over to, we said, I'm cognizant of the fact that we said we weren't going to talk about COVID, and then we're talking about COVID. So I'm going to start my slideshow here and advance to, so 2020 developments in medicine. New American Cancer Society guidelines issued. Peter, can you tell us about that?
Yeah, so there's some brand new American Cancer Society guidelines. These are updated, not even annually. Every couple of years, there's new. They look at they have a consensus panel that comes together, and every few years, in this case, the last one was 2012. Some specific recommendations might be tweaked every couple of years. So this is pretty big. This has been 8 years since they've come up with something, and some of it's no surprise. Increased evidence on eating better to have less red meat for cancer, fewer processed foods, reduced salt intake. One of the unique things they really underscored was limiting alcohol consumption as well. And that's a bit of a theme that's been coming out recently in the literature, is that any kind of alcohol increases the risk for several types of cancers. Even alcohol, and we would say, even at Medcan, we say, well, if it's 7 drinks a week or less, the risk is low, and it is. But what their Cancer Society is really discovering, looking at some very large studies, is that even fairly moderate alcohol intake over a prolonged period can be negative in terms of cancer risk. And we know, red wine is actually good for the vasculature. So a glass of red wine a day has been shown to be beneficial from a cardiovascular perspective, but not so good from a cancer perspective. So, like so many things, there's sort of a yin and a yang to some of these things that we all have to deal with. So that was one of the big takeaways. And one of the other themes was increased emphasis on physical activity. When so much and one of the other questions we're going to be talking a bit about exercise, but exercise, not even super strenuous exercise, but 30 minutes of aerobic and mixed with a bit of anaerobic activity every day. And I always counsel patients that it needs to be kind of a daily habit, not even thinking on a weekly basis, that if you can do that on a daily basis, you are actually significantly reducing your risk for several types of cancers, in addition to the other benefits that we can talk about in a little bit.
That's fantastic. Yeah, I mean, so so it's almost, they went from, I guess, 150 minutes a week to a range from 150 to 300 minutes a week, which, I mean, it's almost a doubling, or I guess it is a doubling in one respect. That is a big jump, and we'll come back to the theme of exercise later on. Okay, so next, we have a new way to screen for heart disease in asymptomatic heart patients. Do you want to talk about that?
Yeah, pretty excited about this from a Medcan perspective, because it looks like we're going to be the first in Canada, especially of an independent clinic, that's going to be able to offer this. It's called high sensitivity troponin, and troponin is a breakdown product that we have measured for many years, and it's a breakdown product of heart muscle. So if you end up having some chest pain and we think that you're having a heart attack and you end up in the emergency department, guaranteed one of the blood samples they're going to draw is something called troponin. And so what we want to see is the troponin high, and you actually may have several taken. Is it changing? Is it getting worse? in which case we need to get you to the operating theater quickly? Or is it on its way down, in which case we think we can maybe hold off the urgency and maybe treat with medicines? But troponin will tell you that there's been some heart damage, and we can pick up that damage in a blood sample. So we've known that for a long time. Most recently, Abbott has come up with the Health Canada approval for a new type of troponin, and it's called high sensitivity troponin. So it is so sensitive that we're part of a global research initiative that's looking at how early you can tell that some people, if you have just even a little bit of narrowing in your arteries into your heart, and you might not have chest pain, you're exercising regularly, but a little bit of narrowing is enough to stress the heart and enough that you actually start producing a very low dose of troponin in your blood system. And so the test now has come so sensitive that we can pick up that low dose of troponin, that low concentration of troponin in your blood system. And it's looking like we can predict 10 years in advance of your first symptom for those individuals that are at risk for having a cardiac event. So this is really interesting stuff. And we're going to be we've been coming out of our COVID self-isolation as well. And as we're doing that, we're now going to be incorporating the high sensitivity troponin into our annual health assessment for everybody as a way to screen for any kind of risk that might be lurking, where even at Medcan, maybe we could only find it when it was there. And with this, we're able to see many, many years in advance who's at risk and who requires earlier interventions to push that risk off indefinitely. So pretty exciting stuff on HS troponin, Chris.
So it's not even asymptomatic heart patients, it's asymptomatic patients, right?
Yeah. It could be feeling completely well. I exercise, I play tennis every week. I ride my bike, no chest pain. And yet, in the blood sample, we could tell that in fact, those activities, while they're great activities, even if you're at rest, we can pick up this very low concentration of troponin in the blood system in some people.
That's fantastic. That's really exciting. Okay, next one. And another one, I mean, troponin, the HS troponin kind of sounds like science fiction a little bit. And then this one, I mean, if we're talking science fiction, this is really kind of fascinating thing. So a potential gene editing therapy for reduction of cholesterol and triglycerides. What's that about?
Yeah. So I think everybody has heard, whether it's 23andMe or, we can now pretty easily, through a very simple sample, get somebody's genetic profile. And it can be sort of a cursory, small kind of image, or it can be your full genome, like the full on all your genes. And that's interesting to some extent. If you're 23andMe, it's mildly interesting, but from a physician's perspective, it's super interesting because number one, and where the stage we're at these days has been, based on your genetic profile, we then can say you're at more risk for X and less risk for Y based on your genetic program. And so, interesting. So if you knew you were more at risk for, let's say, cardiovascular disease, you could double down in terms of getting on cholesterol-lowering medication early, blood pressure control early, exercise, diet. And so knowing that you're at higher risk than the next person might motivate somebody to take on some really interesting and preventative treatments. This study is now moving to the next level, which is if we know that you've got a bad gene or a group of bad genes that has a bad outcome, can we actually tweak that gene? Can we shut it off? Can we take it out? Can we modify it? Can we overrun it with another type of genetic therapy? And that's where we are. This very interesting study that just come out, looking at monkeys. They found out there was two, and of course we share very, very, very closely our genome with monkeys. And so looking at these particular monkeys, they had a couple of genes. When they both get together, they cause higher cholesterol and higher triglycerides or fats in the blood. And so they were able to literally with an injection switch off those two genes. And as a result, the monkeys that had this therapy, for the most part, had much lower cholesterol and lower triglycerides than the controls who didn't have the genetic therapy. So when you start to talk about this kind of, and we actually falls into the category called precision medicine, when we start to be able to be that precise in literally shutting off a gene, we're talking about eliminating disease, so eliminating cardiovascular disease or significantly reducing burden of disease in an individual person. So very exciting, you know, this was a bit of the holy grail that started when genome testing initially started. It was like, maybe someday we can pick out the gene and not just tell people they have it, but actually do something about that gene so that the expression of that gene in the body is actually modified in some way. So this is pretty exciting stuff, because it is what the future was promised many years ago as the genetic work started happening and becoming more commonplace. You know, many people have their genome tested, and in fact, many of our clients at Medcan have taken advantage of our genetic program, where we would do the testing and then overlay the counseling on top of that. And clearly, not today, but in the future, we'll be able to most likely offer some sort of genetic therapies as well. So very exciting. Not a huge study, but it is a harbinger of more to come for sure.
Well, that's really, so actually, even if you're one of those people who tended to have bad genes, or you just luck of the draw, you got bad genes, this is a way to fix that, essentially, where you can, a doctor potentially, you know, decades from now might be able to go in and just kind of reprogram your genetic heritage in order to help you live more healthfully and long.
Yeah, that's exactly it. It sounds like, you know, something from Star Trek, you know, but that's exactly where we're headed. And, you know, whether it's years or decades, we're definitely headed in that direction. Obviously, there's a lot of learning, because if you start shutting off genes, you better know exactly all the benefits that they have and the liabilities, because you don't want to be shutting off any of the benefits that they have as well. So I think most scientists are going into this very, very carefully, because you are actually, you know, messing with somebody's genetic profile.
That's fantastic. And yeah, that's good to remember. Okay, this tangentially involves COVID, or might be symptomatic of COVID. So delayed screening measures create potential for pent-up morbidity. Let's talk about that.
Yeah, it kind of goes to my earlier comments. Everything that we've done has been right. You know, across Canada, I'll just talk about Canada and Ontario specifically, but across Canada, you know, different approaches, but they've all worked for the different regions that they've been applied to. So that's been good. The problem has been that, and again, these are not black and white decisions. These are very hard decisions. So, you know, we want to lock down, self-isolate. Everyone's sheltering at home and sheltering in place. The economy suffers. And the other thing that happens is people are not getting healthcare. They're putting off going to the hospital. Hospitals are being reconfigured away from the traditional services that they provided to provide for COVID-related services, whether they arrived or not. And so either from a fear factor of going to hospitals, because that's where COVID is, or the service is not being offered, or policy saying they're not being offered. So elective surgeries are the best example of that. And elective surgeries in our healthcare system are necessary surgeries. They're not frivolous. You know, we're talking about people that have been waiting maybe a year to have their surgery, and then being told that they're just going to have to wait a little longer. And where the line is between sort of urgent and non-essential or elective, that's a really tough line to walk for our surgeons and for our healthcare practitioners. What's been happening is there's now been 53,000 elective surgeries have been put off in Ontario alone. Multiply that by several fold if you're looking at all across Canada. And it's looking like it's going to take 2 to 3 years to clear out the backlog. And that's people that desperately need these surgeries. These are people that, need a knee replacement, and every day, they're suffering. They have pain, and, they can't even mobilize. They can't walk because they're in so much pain. And yet they're being told, well, we'll get to you in, I know you've been waiting a year, but it's going to be another 8 months until we can get to you because of the backlog. So there's that. There's people that have put off having mammograms, all the screening tests that we would do. So how many people have not had their mammogram and have had a breast cancer that's now developed and requires mastectomy, where before it could be a very simple little procedure? Colonoscopies, people aren't having the colonoscopies. How many colon cancers are we going to find as we start to get back to regular business? So there's a burden of that, we call that morbidity. So there's a morbidity and actually a mortality that's attached to the lockdown, to the self-isolation, and not just physical health, but obviously mental health. No one's really tracking the suicide rate. We'll be looking at that. Are people, they've lost their jobs, they've lost their businesses have gone bankrupt, and they're self-isolated. How many people have actually taken their own lives in those situations? What's the morbidity of depression on our society, on our productivity? These are extremely hard to measure, and even harder to weigh against, again, case rates going up, hospitalization rates going up from COVID. And so what we're seeing now is the reality is starting to hit, that we're going to be seeing more impact on our healthcare system over the next couple of years, just trying to catch up. And that's assuming that there isn't a second or a third wave to slow us down as well. So just really underscores the challenges and the difficulty from a public policy perspective in trying to get the right balance between protecting the population, but also, providing care for the population as well. Like, everything from dental care to medical care to mental health support, all of that, you just can't just shut the spigot off and not do any of that without having some major impacts downstream. And we're there now. As elective surgeries are coming back online, we're starting to see more and more of that pent up morbidity. And again, these people who were easier surgeries before are now more complex surgeries now. And there's just a cost to that. Longer stays in hospitals cost the taxpayers more just for that piece alone. So, and then there's the whole long-term care home capacity, which has been reduced because of COVID. That has an effect on people's health as well. So just really challenging times and very difficult decisions to be made at a public policy level.
There's British Columbia, which has been a leader on a lot of different levels, estimated that it would take 17 to 24 months for them to deal with their backlog, if as of today, and that's not even taking into account a second or third wave. So yeah, it's that's absolutely a tricky thing to manage. Okay, moving on to the next one, which is maybe a little more happy. Peter, you and I are both big believers in the power of exercise. Study ever of changes exercise triggers in blood chemistry. So this is something that landed I think in May.
Yeah.
And do you want to talk about that a little bit?
Yeah, so I think we're all pretty aware of the benefits of exercise, but exercise, huge, like having an exercise, literally prescription. Exercise is medicine, right? And it helps mood, it helps cognition, your thinking skills improve with the kind of aerobic and anaerobic exercise we're talking about. Bone health improves. Obviously, cardiovascular risk improves, cancer risk reduction, as we just talked about a little earlier. Weight management, if you're a little lighter, it means your knees aren't going to wear out as early. Certainly diabetes, all of these things are benefited by exercise. There's not many drugs that we as physicians can prescribe that can do all of that, and with no real side effects. So exercise is what the body was meant to do. This tougher when we're, sheltering in place, but that's why we need to get out, and especially now, get the exercise done. So that's all. We've known that for many years, that benefits of exercise. This study looked at blood chemistry in particular, which was sort of interesting, and they looked at 17,000 different types of molecules that are circulating in our bloodstream. And it turned out about half of them changed, and in a positive way, with exercise, and actually with not that much exercise too. They were looking at, again, sort of 30 minutes, 4 to 5 times a week. And it was really quite amazing. And when I read the study, I remembered back many years ago, looking at cardiovascular physiology. One of the benefits to even exercise and immune status. So we're not talking about COVID, but I'm circling back to COVID here a couple of ways. But one of the things that we found years ago is the lining of our blood vessels have a lining of white blood cells. And when we exercise, those white blood cells, they do what's called demarginalization. So they leave the wall and they enter the blood system. So as we exercise, we actually have more white blood cells. These are the white blood cells, or the blood cells that fight infection and keep our immune system strong. So we know that when we exercise, we have more of those white blood cells available to fight off infection and to keep our immune system as healthy as possible. So that early work really led to some of this work at Stanford that looked at these. Not 100% sure what this, what 9,000 improvements in the molecule, what that actually means. But so I think there's more work to be done, but great early work, and underscores one more thing that why we should be exercising on a regular daily basis if we can.
That's fantastic. And it just goes to show how much activity actually changes you, as you know, and how important it is. It's fantastic. So we received a lot of questions in advance of the webinar. We're going to try to work through a couple. We are over time, but so we'll work through, I guess, probably 2 quick ones, and then I think we'll have to sign off. So one of the questions: have there been any recent developments in the area of dementia or Alzheimer's? Do you want to talk about that a little bit, Peter?
Yeah, there was a recent study that came out that looked at inflammatory bowel disease. So IBD, inflammatory bowel disease, basically is Crohn's and ulcerative colitis. So colitis, colon, itis, inflammation. So inflammation of the colon, and Crohn's, again, a different type of variation on a theme, but basically inflammation in the gut. And the study looked at quite a number of people that had IBD, followed them for many years. So it was a very large and long study, went on for many, many, many years. And they found that if those people that had inflammatory bowel disease had a 6 times increase in the risk of them actually having Alzheimer's disease, and a 3 times the risk of having other types of dementia. So you kind of go, okay, that's pretty big news, but it does actually make sense, because for the last number of decades, there's been the inflammatory hypothesis behind Alzheimer's disease. So that we know there's inflammatory changes that happen in the brains and the neurons of individuals that have Alzheimer's. And so it's not too much of a stretch to think that we've got inflammation going on in the brain, and we also have inflammation going on in other parts of the body, and that maybe these things are connected. And this is the study that has connected those two. And it's tough to do, because you have to literally follow people for many, many, many years to see which ones are going to have Alzheimer's come forward to the surface, and which ones will not have those symptoms at all. So yeah, very interesting, and mostly because it does support the hypothesis behind the inflammatory aspect for the cause of Alzheimer's. So kind of makes sense, but also surprising that it is a 6 times increase in the numbers. So very interesting, and also may support some of the earlier hypotheses around what's the cause of Alzheimer's disease.
So you have these two supposedly unrelated conditions, and so on some level, this sounds like a head scratcher, but actually what's happening is that they're both tied to inflammation, and so that's this underlying condition. So it speaks to the harm that long-term inflammation can do to the body.
Yeah, exactly. So, and again, the next thing is, so what? The study did not look at if we treat inflammatory bowel disease, do we then reduce the risk of Alzheimer's? That they didn't look at that, but obviously that's the question that this begs. That if you treat inflammation in your body, do you actually reduce the risk of Alzheimer's? And there's research going on in that area, but the verdict is out on that just yet.
Okay, last question, and this one is something that you've been working, and Medcan overall has been working really hard on over the last, since the pandemic. What are your views on the emergence of telehealth, video consultations, and other remote medical technologies? Are they valuable or dangerous? And are they here to stay?
Yeah, well, they're here to stay for sure. Dangerous, I think, no. Utility-wise, I think is massive. Like, we're not going to go back to the previous way of doing business from a healthcare perspective. You know, as our population has been able to work through having a remote connection, as we're doing today, versus having to be in the same room together, and supported by technology that allows this. As 5 years ago, even we didn't have Zoom at least to the extent that we do now, and the Skype calls were real jerky and they were just super frustrating. So it was a combination of the technology now is more ubiquitous, and it's more slick and more seamless. Apps are working very, very quickly. As we're moving to more of a 5G environment, that makes the whole thing work a little bit easier. So all good on the technology front. From a utility perspective, it is beneficial for more minor physical concerns, and which is many, like that maybe the bulk of healthcare maybe defined as relatively minor concerns as opposed to life-threatening. And certainly on the mental health support, where we're working through, and we don't have to be face-to-face to work through a counseling session. So massively important there. For many years, Medcan has had a virtual approach to mental health. Weight management, we have an amazing weight management program that's been largely virtual, so that our population is literally nationwide in some of our programs, as opposed to being focused around Toronto or Ontario. So we've already been there. This no crisis wasted. The COVID allowed us to really spread our wings in this regard, and I don't think we're going back. But there will always be that necessity for being face-to-face with a physician in the same room. That might be physical distancing would be involved, PPE might be involved, so it might be slightly different. And obviously our hospitals are still required, and as our earlier discussion, needed more than ever. And you just can't have an appendectomy virtually. So you're always going to have to be pretty close to a hospital to have any procedures done, diagnostics done. But for many of the concerns that are our day-to-day concerns, and we just need some advice, fantastic platform. We're really excited about our ability to leverage the technology and to spread basically that Medcan kind of service right across Canada.
Fantastic. Thanks for that. I'm just going to take a minute to talk about future webinars. So upcoming weeks, I am going to share my screen here. So this was the medicine without the COVID. So next week we have border crossings, long and short-term considerations for travel to the United States. So that's basically about how and when we will be able to travel to the United States. And if you decide that you do have to go, what steps can you take or should you be taking to mitigate risk? After that, the week of Tuesday, July 21st, How to Fly, which is kind of a cheeky title for how to go on an airplane. So should you just avoid air travel altogether? What if you have to fly? What's the best way to do it safely? Is it enough to wear a mask and use hand sanitizer frequently? So that's Dr. Aisha Khatib, who's clinical director of Medcan's travel clinic. And yeah, we have huge numbers on that webinar already. That's going to be a great one. And finally, in July, Tuesday, July 28th, the second wave. So epidemiologists predict a second wave coming this fall, and how should employers prepare? What are the best practices to mitigate its impact on work sites and productivity? So that's an exciting July of content. How do you sign up for these if you are trying? So let's go to the Medcan webpage. We scroll down, and we are tweaking this system now to make it a little easier to join up with this stuff. So then you go to the our community health page, go down, and then there's the Medcan activities. So you click on the full month activities, and then there are clickable links to sign up for each webinar on Tuesdays right there. So I'm going to stop sharing. Thank you to webinar attendees. Thank you to Dr. Peter Nord. Any final thoughts or comments, Peter?
No, we've covered a lot of ground. We went a little over time this time, but but it is a topic. There's lots of things that are happening besides COVID, and you know, again, that pent up morbidity is what we're going to be facing now. So thanks for having me on again.
Yeah, fantastic. So that's great. Thanks to webinar attendees. Thanks to everyone. We'll post this on YouTube, and we'll send around a link to all attendees either later today or tomorrow. Thanks very much. Okay. Goodbye, Peter. Goodbye.
Bye now.